Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I am with a plethora of people here. Let's go around the room. Jake, would you mind doing a quick introduction of yourself?
Hey, what's going on? I'm Jake. I'm currently the Ranger LNO at the Special Operations Combat Medic course. I'm still in the 75th Ranger Regiment, and I also teach at the SOCM Skills Sustainment course occasionally.
Very good. Jeremy?
I'm Jeremy. I'm an SOIDC. I am the Navy LNO at the SOCMS course up here at Fort Liberty.
Very good. Brenton?
Yeah, my name's Brenton. I'm a Navy SEAL and a SOCM, and I'm currently running our TACMED program, recertifying and training the SEAL medics on the East Coast prior to heading out the door for deployment.
Very good. And last but not least, Paul, how are you doing today?
Hey, I'm good, man. I'm just a retired SF guy.
Hell yes. Hell yes. So, the reason why I brought all you gangsters on here is a lot of providers that I encounter, whether that be civilian, whether that be military, coming in, almost, I would say almost universally, minus, a select few, actually know what it is a soft medic is, what a soft medic does. There are so many flavors of soft medics. I think it's kind of behoove us to kind of explain what we do and how we get our job done. Where do we fit in the continuum of care of the patient, right? So, Jake, if you wouldn't mind starting us off, what is it you say you do here?
All right, so kind of to break down the 75th Ranger Regiment as a whole, so we're primarily a raid force. We also do kind of large-scale SOF operations. Think kind of like a infantry unit that's pretty specialized. The medics reflect that. I guess at a baseline, you would expect our guys to be very proficient at TCCC. We don't get that much further than that, to be honest. We've definitely identified some gaps in transport and extended hold capability that we've addressed with, critical care and flight paramedic, but we don't go to the SOCM long course. To specify kind of the TCCC capabilities, I would definitely reference, kind of Paul said last time, the fourth tier of TCCC, kind of that highest level, the provider/combat paramedic version of TCCC. But there's going to be some differences, like there's going to be for kind of all of us. We all kind of do that stuff, but there's definitely some unit individual differences. We're heavily influenced by the Ranger Medic Handbook and by our chain of command. We're very centralized in the way that we do pretty much everything, which I think there's a lot of value in. That handbook is kind of our Bible, our standing orders, if you will. We don't really work off of, we don't make stuff up. We just do the basics really well. And I think that's kind of the hallmark of our organization as a whole, is we just do the basic stuff really well. We do it over and over and over again until you honestly get bored with it and you can't really mess it up anymore. The two types of medics that you'll likely experience in Ranger Regiment are going to be your company senior medic and then your quintessential Ranger medic, the platoon medic. The platoon medic supports the platoon. He's typically on an operation co-located with the platoon sergeant. The platoon sergeant is kind of the de facto leader on the ground in our world. We're always kind of an NCO-driven organization, like most SOF organizations are, and that reflects tactically. He's kind of enables freedom of movement for the platoon sergeant across an objective. His gun is pointing where the platoon sergeant's eyes aren't. He's allowing him to do what he needs to do to get the things done, to place himself at kind of points of friction across the battlefield. The company senior medic will typically have 4 of those platoon medics underneath him, 3 to 4, depending on the company. He will typically be attached to the first sergeant operationally if that element goes out. Typically, the company senior medic will actually go out operationally as well. The scope of practice is a little bit expanded for a company senior medic. They say, in our 350-29, the RTC 350-29, which is kind of like the regulations that determine our actual like job description. It compares us almost to like an APP, but it's not an advanced practice practitioner, but it's not really like that. It's definitely reduced. From a pre-hospital standpoint at the POI, I think we're doing as high level as you're going to get. I think as you start to retrograde back to a clinic or something like that, we are not APPs. We are medics for sure. And that's really all I got, unless you guys get any questions.
I mean, like advanced surgical procedures,
tons of those.
Airways, chest tubes.
Yeah, tons of emergency thoracotomies and stuff like that. All that crazy stuff. Amputations. Just kidding. So we're gonna do So the basic SOCM skill set. So you're gonna have the skill level 1, initial entry, whatever, just get to battalion, they can do a chest tube. I promise you right now, they'll do a chest tube. The crikes, they're going to do crikes. They're going to do any, pretty much up to the gambit of the echelon of the SOCM scope of practice. The Ranger private medic is supposed to be able to do, and I would say by and large that they all can for sure.
Okay. Yeah. Giving blood, they carrying narcotics. What kind of narcotics?
Yeah, so we all carry blood. I'd say in my experience, I would typically carry 2 units if possible. That's obviously dependent on the amount of blood that we have at the time. I would usually make my guys carry 2 units if possible as well. In terms of narcotics, I would typically carry and midazolam, usually around like 50 milligrams total. That came kind of later in my career, unfortunately. I was always carrying about 4 milligrams total until we realized that maybe wasn't enough. Always ketamine, usually about 2 grams total. That just also depends on kind of what's going on. And then it would be like an OTFC, so a fentanyl lozenge style thing. I usually carry about 3 of those. And I would carry usually around... I don't remember specifically the amount of Dilaudid, but I would always carry Dilaudid as well. I've also been exposed. I've deployed with sufentanil, although I don't have any experience with it at all.
Okay. All right, very good. And they get their kind of daily experience in the clinic?
We
like
do.
Sickle type clinic?
We do see, we're responsible for the platoon, and the company is kind of just general primary care stuff. We're the first touch point. We kind of triage there, and then if we can't deal with it, we'll send them up to the battalion aid station or to the whatever clinic that guys have access to. It's dependent on battalion. But a lot of the stuff we just kind of handle in-house at the platoon level.
All right, cool. Very good. Jeremy, you're up. So what is it exactly that you do here?
Yeah, so...
I mean, an SOIDC, like said, not just you.
Yeah, so SOIDCs, we're also, depending on who you ask, we can be referred to as FMF Recon IDCs. But I feel that we're probably, as far as providers, unique because SOIDCs are also providers. So we go through the first portion, SOCM, and then SFMS. And once we graduate SFMS, the Navy recognizes enlisted providers. So once we get that, we become SOIDCs or FMF Recon IDCs. So we actually have MPI numbers. And so basically what that means is we can, CONUS, we can prescribe meds. We have a formulary that we can go off of, like that, certain privileges, but we can't, for the most part, like prescribe everything besides controlled drugs. So narcs, any psychiatric things, stuff like that, we can't do. But we do have a supervising physician as well that we have to do. But essentially, we also, I think, much like the Rangers, where there's some similarity, is we stay medical primary throughout our careers. So, for me coming in, I started the pipeline when I was an E3. I was an E4 when I graduated, and I've been doing the same thing all the way up into E7. So medical stays are primary. It's generally broken down like where we have 2 per team. You have a junior and a senior, and then each one will go into an element. And then for quote unquote the big mish, you always have one usually back at a C2 location with the nerd shack, all them people, and then one will most likely be on main effort or whatever is the main effort of that mission. So we're broken up and we're mutually supporting each other. And then obviously we have what we call a med chief that's at the company level, who's there supporting us as well. And they're pushing down resupply, stuff like that. We're also, again, since we stay primary, we harp that level 4 TCCC, but through our FTXs and through our medical training scenarios, we hit PFC or PCC or whatever flavor of the month, whoever's calling it, whatever doctrine is deciding what we're going to call it this week. So we hit that as well. So you laugh. We all know what we're saying. It depends on who you talk to, what you're calling it. But yeah, so we go that longer term thing, and we do training that supports it. Prolonged field care training with Ragged Edge. We go out there and do that with them as an enduring training. But as far as narcs, I'm just going to go off and kind of piggyback what you asked Jake there. If you're not cheating, you're not trying. Fentanyl, Dazolam, we carry Dilaudid or hydromorphone, ketamine, and then that's pretty much the standard formulary for any SOIDC. As far as controlled, and obviously the fentanyl lozenges as well, we'll have those. And then, what else you got?
Yeah. No, I think obviously you said you go through the SOCM course. What is it that is like super magic and amazing at the long course that you guys go through?
Well,
can you do Raboa?
Hard no. That's almost a dollar in the swear jar. That and the word austere. If you say austere or Raboa, that's $1 in the swear jar. No, getting the understanding X-ray capabilities, being able to take that and deployment setting, obviously the lab capability, which is funny because I don't know any internal MARSOC team that has any lab capability, but we get taught it. I'm really good at spitting down poop and looking at it, and then what else? Yeah, and then the surgery and anesthesia. But for the most, I myself have never dealt with anything that needed that, and especially because I think it used to be dental used to be in the quote unquote SFMS portion, the long course, and then it's flip flop a couple times. So dental, what I say, since it's in the long course or in SOCM now, I think that'd be another big benefit of the older generation SOIDCs having dental. That has definitely come up on a couple, but nothing too magical with SFMS. But again, like since medical is our primary, we usually try to do MPTs or cross training with doctors and like, hey, how can we better take care of our patients for longer periods of time with little to less than what you would be comfortable carrying. So,
yep, very good. Brenton, you're on deck. That's what is it a SEAL medic does?
Yeah, so SEAL medic, I would say, is probably most comparable to a Ranger medic as far as our actual mission set. Ranger medics probably scoff at that a little bit, but I would say as far as being DA oriented, that's probably the most comparable. We have an older generation of guys, myself included, that are SOCM graduates, and then the newer guys are going through our own schoolhouse. We tried to pull a PJ. We'll see if that sticks around, but that's where we're at for the moment. As far as going out, we've been extremely DA oriented, so it's been point of injury care, really good TCCC basics, and then loading them onto a bird that's 10 minutes out, and shipping them off. I think recently there's been a pretty big push for, a lot more extended, and expanded capability of care. So PFC has been a big push, sending guys to Ragged Edge courses like that. We've also started to get more into like Arctic warfare and Arctic medicine. There's a huge emphasis for us about going back to the water and doing maritime medicine. So we started sending guys to like chamber operator, inside tender, so they have the dive medicine capabilities. We also are we set up a bunch of relationships where we're sending guys, like Harvard to do ultrasound, advanced CBRN, a lot of stuff to expand on the deficiencies we have had outside of probably clinical medicine is still a big weakness, I think, for us. We're not in the 18 Delta wheelhouse there. As far as what we have rolling out the door, so each team has a couple of troops in it. Each of the troops has a couple of platoons, and you're looking at probably 2 to 5 medics depending on the platoon. So you'll have a senior or a couple senior medics and a couple junior guys. Everybody goes out the door with narcotics. We carry blood, cold chain when we go out. We also do type and titer prior to deployment, and so everybody carries a what we stole the Rolo and we call it Solo, so it's COLO titer. Yeah. But so yeah, but I mean, so everybody is able to draw when they roll out the door as well, and then our O guys are identified for narcotics. We're really heavy on ketamine and Versed. We also carry IV fentanyl, and then we do either fentanyl lozenges or we have the sufentanil little tablets, it's almost like a stapler mixed with the Pez dispenser. So that's kind of, a flavor of the month, whatever's in the shop when guys are getting their loadouts. Any burning questions, I guess, outside of that?
No, we're not interested in SEALs, but obviously you're a SOCM. We're going through the same course, so generally we're having the same capabilities. At least the older school guys. For the SOTMs, the new generation, are they essentially getting the same type of training, or is there a difference?
Yeah, so the whole reason for starting it was to not send guys away for 9 months or prior to that long course for 13 months, and it was 6 months originally. Now it's 9 months. So there's a lot of talks in the works. We'll see if that stays around or if we're going to send dudes back to SOCM. Our schoolhouses, we've been working to get them ATP accredited for refresher sustainment. We're pretty much there. So I think there is a push towards that. As far as what the guys are actually getting in the schoolhouse, I would say they're coming out with an NRP, so they're paramedics. They're obviously not getting ATP quals out the door. And I don't see that happening based off the last audit really anytime in the future. They do a very good job of March, like March squared. I would say they are very strong in that sense. When it comes to a lot of the ancillary stuff that you learn in SOCM or beyond for the long course dudes, it is lacking, I would say, at a minimum. And I would caveat it with, I think with a lot of the training that we offer post, I've seen guys who are, long tab 18 deltas that are absolutely trash medics and they don't pursue the skill. And I've seen SODMs that love medicine and that's all they do. So I think where I would say the biggest difference is the baseline coming out of the schoolhouse is obviously higher as you go up with more training. SOCMs, I would say, have a higher baseline. Deltas and SOIDCs have a higher baseline than that. I would say SODM is probably on the lower end of the spectrum with a lot of the like clinical ancillary stuff, but I think that's probably the biggest differentiation, is how you said that word, between them.
Yeah, I would definitely agree with that. Just obviously, I would never was one because I have morals, but I'm sorry. Like it was a softball, and I couldn't help it. But 100% seriously, definitely very good at T-Tri-C. When it comes to that, those SODMs are all over it. I would say where the wheels start kind of shaking is when you start doing that extended care. You start thinking about those ancillary things, long-term pain management, nursing care, vent management, airway management, like all those things start adding in and the wheels start shaking. However, definitely very smart, motivated young men and more than capable of doing it. They just never been taught it to begin with. So can't fault somebody for that.
I would also say, I guess one caveat as well. I think a big difference for SEALs as well, probably from any of the other medics, is you're not just a medic. So obviously you're an assaulter first, but it's not like you're a Delta and you're a Bravo, you're Charlie, and you have a job. For us, it's you can go to breacher school, you can go to sniper school, you can go to JTAC, and you could also be a medic. And that's one of 3-4 hats you're having to juggle. So I would say for the most part, medicine is not a priority for a lot of people because you have to be good enough. You're a jack of all trades, master of none, really, I think is how a lot of guys look at themselves. So I would say there's a lot less people who are really diving deep into medicine, and medicine's my passion. That's all I'm going to do because I might have to worry about 3 other things that I'm responsible for. So.
Yep, absolutely. Last but not least, Paul, what is a 18 Delta? Yeah, sorry about that.
All right. Yep.
We'll cut everybody else out anyway.
Yeah, no, just going off of what Brenton said, I was thinking about it. We are similar in the fact that if you look at our ID cards, there's no Red Cross on it. Like your medical job, even though it's part of your MOS, really becomes the thing that you do after everybody goes home. It's like your secondary job. So yeah, sniper school, whatever, you have all the opportunity in the world to forget about medicine and never have to touch it again until you need it. So that's the thing though. When you're on a team and you're somewhere in the middle of Africa, there's no PAs that are with you. There's no surgical teams. It's just you and the patient. And so sometimes you got to remind the 18 Deltas of that. And I think a lot of them are realizing that with the change in operational environments. Mostly what we do is we train and operate with partner forces across the whole spectrum of SOF activities. So anything that you could think of, we're doing ideally with a partner force so that we can kind of pick them up, show them the way, and then they can run with it by themselves. Whether that happens or not depends on how long we're there, what kind of resources we have, what kind of missions going on. But we used to focus on clinical medicine quite a bit more, in my opinion. Once the course changed, things kind of changed. We started looking more at trauma. When the SOCM course went to 9 months, we had no more clinical oral boards that we used to do. We still have the vet medicine. We still do dental stuff. Like Jeremy was talking about, not many people have done an amputation in combat. It's probably not a thing that happens very often, but I think that advanced wound care, if we show the guys that this is the worst that it should ever be, then they should be able to handle everything from that point lower. So having taught that course, to me, it was really valuable. I've had some weird wounds, but I'll tell you, I've never had a wound in training that I had, in a deployment or on combat. So, like one time we had a guy get in a fight with the local police, one of our partner force, and got his cheek ripped off. And now that's your patient. You have to do wound care on that dude's cheek. That was a thing. If you figure out how to keep wounds clean, what not to do to wounds, I think that's pretty important. So, along with that, these procedural sedation skills kind of come in handy. When to use them, when not to use them, like hypovolemic patients get a lot of use with propofol. You do some regional anesthesia, and that way you're providing pain with the regional and you're providing some sedation with some of the other drugs there. Pretty much everything across the spectrum. I mean, like I said, you can go as deep or as shallow as you want in a lot of those things.
Yeah, absolutely. And I mean, obviously all of us are kind of, medicine is kind of our thing, and that's why we teach it. That's why we're on a podcast like this, right? But pick an individual within our ranks. Some like medicine, some do not like medicine, and those who do not, they do not practice it, right? And I think that's probably true across the board for any service. If you guys, you had a new doc come in, other than what we just talked about, would there be anything else you would want to add to tell them about this is the type of person you're getting ready to receive? Jake?
Yeah, I mean, I think our personality just as a whole, I think SOF medics are oftentimes more similar to each other than they are to the other people in their organizations. That's what I've found, at least. We all kind of have this one common, pretty difficult school that we all go through together, and I think that it's hard to not have that rub off on you a little bit. Building rapport with us, I think, is pretty easy, but I guess managing the personalities standpoint of each and every one of us is something that I would can be a challenge, I think, for sure. But it's really it.
Okay, cool. Jeremy?
New provider.
Yeah.
Oh.
New provider coming in. This is what you're getting ready to receive. What would you like him to know about the medics that are within?
Yeah. Well, like most things, I also did forget. Brent, he talked about diving, right? So all of our providers that we have, as far as doctors go, have to be dive medical officers. So they have to, they go to underwater medicine, rad medicine, and they go to dive school. They're divers, and they go to their dive medicine portion as well. But we're also, we go to dive and dive medicine as well. And then for our dudes, it could be, since we do stay medic centric on this, is you may get a guy who has 5-6 deployments and has been on the team the whole time, and his experience is going to be vastly different than a guy who's been 2 teams and he's been at a different AO or non-kinetic AO. So being able to balance that and to challenge us medically, that's another big one. Is a lot of us want to stay sharp on our clinical skills, because I think, like most of us throughout our deployments, we realize that 95% of what we do is the clinical, the sick call, the rare impetigo that someone gets, and you're like, cool, dermatology, I'm going to nail this one, right? So being able to go through and challenge the SOIDCs and being able to teach them. And again, understanding you're getting a gambit. You're not getting, yeah, cool. I know you're in a, on a team, so you have 2 deployments or less before you move up. It's like, no, you have a dude on a team that may have 6, and the next team over, their senior dude only has 2, and their junior dude just came from the pipeline. So it could be a broad spectrum of knowledge and experience, and being able to challenge us.
Cool. Very good. Brenton? Oh, sorry. Jeremy, did you have anything else?
Nope. No, you'll ask more questions. I'll answer then.
All right. Very good. Hey, Brenton, what do you got?
Yeah, I don't have a whole lot extra to add. I think with Jeremy's point, I think that is huge for providers to understand. I think for the platoons for us, the guys have to have a baseline level of trust with the medic, and the providers have to have a baseline level of trust with the medics as well, and give them the autonomy to be able to work and do their job and feel supported. So I think on that end, that's very beneficial for them to understand. Like, they need to have a baseline level of trust. Going back on Jeremy's point, results may vary. So you may have a guy who tries to put a live bag of Hextend on a role player, and then you may have a guy who's able to do which I've seen, and then you may have a guy who can do a leg fasciotomy in the field by himself and crush it. So the levels of medics that you have, even within, if they're all SOCMs, if they're all SODMs, I think varies. So you need to have trust, but you also need to kind of vet your guys and find out what their levels are, and then do your best to help support the senior medics. And then you yourself as a provider, teach up the guys who are lacking or are more junior and getting them up to par. So give them the resources, give them the support, and then help them flourish, as a medic.
Very good. Paul, new battalion doc, bright-eyed, full of hopes and dreams, coming in. What does he need to know about the medics he's getting ready to sign off on?
Yeah, he's going to have to understand that if he's counting the B teams across his battalion, he's probably got 21 teams that he's taking care of. So anywhere from 40 or more medics that he's responsible for. And they're going to deploy whether they ever meet him or not. So I've had definitely different experiences with some of these battalion PAs and docs, and sometimes you never even meet them. And you deploy, you come back, you draw your meds, you know what I mean? And you live separate lives. They're in the clinic, you're in your team room. So for those docs, get down in the team rooms, knock on some doors, crack a beer with some of the guys, get to know who they are, ask them some questions, and then share whatever expertise that you have. So start simple, like emphasize the SF600 and do just a regular SOAP note. Not many of them are going to have access to Genesis and get on the system and do that stuff, but they will probably take care of their guys if you empower them to do that. And if not, they're just going to send them to the clinic. They're not going to go with them. You'll have patients that show up, and you'll never get to know your medics. So it's a great opportunity to really make some impact in some of these guys' lives and careers. Or you can just do what you want to do and stay in the clinic and moonlight on the weekends and never see them again.
Yeah, I definitely got to agree with that. Communication, incredibly important. And I can only speak from the SF side. Like, we're not actively hunting this new guy down to find out about him. He's going to have to go. He's going to have to knock on the doors, introduce himself, and start to get to know the guys. I don't know. Is that kind of similar across the board? You gotta, where the doc would have to actually put in an effort to find out who these medics are?
Hard no. Hard no from it, because so like our new doctor is our supervising physician. So like we have to go meet him, understand his expectations with patients. You talked about like one thing I didn't quite hit on. I imagine we'll probably talk about later, but like Paul brought up Genesis. Like for one of our battalions, we'll have 21, 22 providers that can see patients, prescribe drugs, like versus, a group or a ranger bat, or a troop where you have your battalion surgeon and PA, and that's it. So being able to, like when we have a new one coming in, it's a pretty known fact that's coming in, and it's like, hey, you need to come in, and because we have quarterly reviews and stuff like that we have to do. Like they'll go through, see our patient list, and they'll break down that patient list. Like, hey, this is what you did. This was your diagnosis. This was your differentials. Like, what do you think? Hey, think about this next time. Hey, on this note, you can write this differently to make it read like this. Stuff like that. So for us, I would say they want to go out and meet the dudes because they're interested, because I think unlike other soft units, that they don't get assessed and selected to come there. They go to doctor school, 10-pound brains, then pick a specialty, aeromed, nuclear med, dive med, whatever the case may be. And then they get sent there, and then they get orders. So we'll be getting someone straight, from the dive medical officer pipeline who knows nothing about the Navy in general, but then they have to get stationed with the Marine Corps. So then, now you're talking, step uncles and 2 Christmases. Things get weird. So.
Yeah, I agree with Jeremy.
Yeah.
So we've got kind of a similar kind of structure there. Obviously, we're not all providers, but we have. You're definitely going to have a relatively intimate relationship with your provider at your battalion. They are Rangers. They have to do the same standards, the same whatever that everyone else has to do. To come to our unit, they have to go to RASP 2, which is kind of like the senior enlisted and officer RASP up to the rank of, I believe it is 03 is when it stops. They have to do everything. They have to meet the physical standards. They have to go to Ranger school, which sucks for them. They have to go to airborne school, all that stuff. And you will, because we're so centralized, you will know them. You will know them, and your relationship can really, really, really shape guys' careers. I remember, and I'm sure we'll talk about this later, but I had my first battalion surgeon. I've had 2. My first deployment, he would sit down with us every day at 2100 that we weren't doing something, and he would do a class with us on some type of clinical medicine thing. Eventually, you kind of it gets above our scope of practice, not out of his knowledge realm. But it got into stuff like finances and stuff, because he makes way more money than all of us, obviously. And I remember seeing his LES and just being, because he was showing us how to read an LES, probably a little slight flex there. But he showed us his LES, and I was like, dude, are you kidding me right now? I'm an E4 making just absolute freaking pennies. But that was a really cool thing. And for me, he's at Bragg now. I haven't reached out to him, but it's definitely something that I'm going to do in the near future for sure. But those relationships definitely matter.
Cool. Brenton, then, how is it on the SEAL side? Are you guys tucked away in your little rooms, or?
Yeah, I'm in because I'm in training shop, I'm right next door to our UMO, and so I think right now it's a little bit different for me as far as the relationship goes. But the way that we break it down is for pretty much all the teams on the East Coast, you have a senior medical officer who's either an 05 or an 06, and then he's paired with a master chief who's some type of special operations corpsman. So it could be a SARC, it could be a diver. Right now we have a SARC. Our previous one was a diver. And they kind of are, your SEMA and your SMO, and they run the enterprise. And then each of the teams individually has a team of independent duty corpsmen who a little bit different than Jeremy. They haven't gone through BRC or SOCM, but they have a different course that makes them providers, and they all fall under a PA. So you have a PA and then IDCs at each of the teams. Your relationship with the IDCs as a medic is extremely intimate. Like, you have an IDC that's for you, and they go everywhere with you. They train with you. They provide coverage for you. And your PA is kind of the next step up from them. You have a fairly good relationship with them. Like, they kind of dictate how the team's medics are going to run, obviously under the doctrine of the SMO and the SEMA, but they are your strong touch point. And then I would say there's a little bit of a disconnect between your actual like doctor and the master chief with a majority of the team medics, and kind of just what gets passed down goes through the proper channels. It's obviously, it's like open door. They could come over at any time and ask questions, but I don't think that relationship with the general team medic is quite as intimate as it is with the corpsmen and the PAs that you work with.
Okay. Do you think it would be beneficial if they did come out of their room?
Yeah, I mean, they come out to do training. They do a lot of stuff to watch, but I think that we just, like, I don't know how it is for the rest of guys, but we travel so much for our training. Like, our deployment cycle is a 2-year workup, with the last 6 months being deployment. And I would say you're gone 6 to 9 months a year. Like, the first year working, which is just workup, and then you're gone for the full 6-month deployment plus some extra time. So I'd say like 9 months ish, 8-9 months maybe. You're gone a year. So they can't travel for all the teams that they oversee. The PAs can. So the PAs do go out and they try to hit as much of the training as they can, but everybody's kind of disaggregated. You could have some people down in Florida while other people are over in Arkansas at the same time, doing different training as they work through. So I don't know how much of a difference that would make. I mean, if they had like a doctor at each of the teams and they replace the PAs, but then at that point you have the same relationship as just with a doc, and they're going to fall under a senior doctor. So I don't know. I think that the relationship is fairly good. I just think that we personally in NSW rely a lot more on the PAs to help out the medics than we do with the guys who are, intimately integrated with their battalion surgeons.
Cool. So, that's, for the docs, this is kind of the medics and kind of the scheme maneuver of daily life for them, right? The flip side of the coin, what the men expect from the doc. So, Jake, if you wouldn't head it off, what is it? You get a brand new doc coming in to, your company or battalion, however it is. What is it you expect out of him?
So that's a pretty complicated question, because for all the reasons that we've just talked about, like the inter-individual relationships between the different people are super important. But what I expect from a doc is not what the chain of command expects from a doc, is not what the platoon sergeant expects from a doc, is not what the battalion commander expects from a doc. It's all different. For our guys, they're usually pretty fresh out of residency. So this is kind of, a lot of times, this is generally their first duty station. Sometimes they have prior military experience. My first battalion surgeon was an infantry PL prior. With that said, we want you to be able to meet that, like the Ranger standard, like there's some physical things that you need to be able to do. Like I don't want to see you as a guy that's going to fail the 5-mile. That's crazy to me. I have to pass it, so you have to be able to pass it too. You have to be able to exceed the standard. In terms of your medical knowledge, like we understand that a lot of our surgeons are not like trauma specialty guys. They're usually family med guys, ER guys, and that comes with a ton of knowledge that they can offer us. But I don't expect you to be like immediately just crushing T-Tri-C. Like I got that. I got that you're off kilter. I get that you putting your knee on the ground versus standing up at a table is totally different. It's not the same at all. I also get that working in the dark is totally different than what you're used to. But I would say, like, for a guy that's coming in, like, understand, like, hey, the language that we've told you now is that we all speak at baseline is the TCCC guidelines, right? We all talk that, and we all solve problems initially that way. If you don't know those, it makes it hard for you to kind of to add value, I guess, to our stuff operationally, because you're kind of missing a huge piece of the pie. All the regulations that determine, like, joint operations, like the Army's is ADP 4-02, and then the joint is JP 4-02. They both specify TCCC as being, like, the thing that we use to treat trauma patients. You know, so that's something you could start off to be successful. But then, like, yeah, I mean, you have something to offer us. Like, we would love to get all the knowledge you can. We as Ranger Medics, again, we do medicine. That is our job. All of us are generally interested in medicine, with very few outliers. We want to know more. I remember as a private, you know, as an NCO, you get busy, you start kind of getting into the whole, like, company operations things, like trying to support your commander, trying to do this, trying to do that, and you kind of lose sight of it a little bit. But getting back to that real clinical piece, the hard, like, hey, what is the value of giving this corticosteroid topically versus this other corticosteroid that, like, matters, you know? And it's something that you can really affect your guy. What is something, hey, physical therapist, that I can do, because I'm going to be the first touch point for my guy? What is something that I can do that can help him out, right? Physical therapy is something specifically in the last 10 years that's changed quite a bit. It's a lot less hands-on and a lot more like just figuring out what's going on with your patient, talking to them, talking about who they are. This, like, whole, like, biological psychosocial kind of approach to things. It's complicated, you know, and a lot of medics, you know, we're taught a very kind of rigid medical model about things, but we're not taught about, like, the human being in front of us. And I think that if a doc can convey that this human being is more than just, like, a group of symptoms and, like, a whole organism in front of you, that's, like, a pretty cool thing. And they get that training. They know that they can convey it. Guys are interested in it, but I think it requires you to be somewhat of a salesman to do it. But it matters. Building rapport in our communities, I think, is, like, I mean, that's it. You know, we're not rapport builders, Rangers, you know, not like SF is, or not like the MSOTs are, but, you know, but in our organization, that matters. You know, how you're perceived by other people really matters. So I think doing the classic new guy thing, and I'm not good at this, to be honest, but the classic successful new guy thing of just kind of shutting up and listening. What do I need to, how can I add value here? What can I bring to the table? They're all smart. That's why they're providers. You know, it's not hard. It's not easy to get there. Like, figure something out and then add value, you know. Understand that we are largely going to be NCO run organizations, obviously with officers in charge, but, you know, at the end of the day, we are still generally kind of NCO run organizations, you know. Building rapport with those NCOs is really, really, really important. One of the, I mean, he's got to be one of the best leaders that I've ever had in the military. This guy he's a PA. I don't want to say his name, but he's still currently in the military. He served in every position up to battalion senior medic in the Ranger Regiment, and then he went to PA school, and now he's a PA. Just the way he would interact with NCOs was on such a peer-to-peer, eye-to-eye level that, like, you couldn't hate the guy. And this is a guy who's gone on thousands of missions. He was more experienced than all the NCOs in the battalion by the time I left. I mean, it wasn't even close. I think guys maybe have a picture in their mind of what a soft guy actually is, but when I think of a soft guy, that's who I think of as a guy like that. Guy's a PA, you know? Meeting people where they're at. Not talking down to them because, you know, you're a doc or you know, they're a medic, you know, because there's definitely something like, I've seen you providers run trauma lanes. It's not always that great. That's right. We've all seen it, right? With that said, you can't offer us stuff like I said before. And yeah, I mean, that's kind of all I got about that.
Just one quick question. So you mentioned, you know, that kind of transition from clinical care to more austere care, like you mentioned, getting down on a knee. Obviously, initially, it's probably a great big shock. And we've all seen it before where a new provider, they are not used to this at all. And it's just completely written on their face. That being said, that same provider now is assigned to your unit. Is it okay that he stays uncomfortable on the ground?
That's an interesting question, Dennis. I think that we are all kind of uncomfortable on the ground. You know?
Yeah, I mean, I like chairs myself.
I like
but
chairs. I like light. But the reality is, it's like this whole job. I mean, that's what it is. It's kind of just being uncomfortable a lot of the times. And when you find the guys that are comfortable, it's like maybe you need to go someplace else and do something different. But like, I think within reason that they need to get comfortable at some point. Like there's, I heard a surgeon. She's a very influential surgeon amongst the joint force. She said, I was really focused on doing surgery directly. And then I realized how much I could affect people across the force by training the medic, You've seen the guys, the Ryan Knights, the Ethan Mileses, the Andy Fishers that have, essentially from a desk, they have reduced mortality across the force, right? By just caring. And there's docs across every type of soft element that have done the same, And I think that's a super cool thing. It's a super cool opportunity that you can reduce mortality and morbidity across the force just by having some good influence and by meeting people where they're at and by building rapport and by really caring.
Yeah, very good.
It's hard to treat patients as a surgeon when the medics kill them on the battlefield.
That's true. That's also true.
Real weird how that works.
Yeah.
Which is a great segue for me now.
Yeah.
So, Jake, excuse me, I was not paying attention to anything you were saying. So, all these thoughts are 100% my own. No, as I'm going to just speak as Jeremy's team guy, because I think Jake did hit the nail on the head. It's like what I want as a medic is 100% not what battalion commander wants, what the sergeant major wants, right? I don't care about any of the nerd stuff, right? So I'm just going to speak. Jeremy's king for a day, and how can he help the team medic on the ground? The first one is be able to trust us. As I don't know if they get taught this when they go through OCS or whatever, but I've had a couple battalion surgeons, like, blood is in our protocol. Blood is what soft medics do. And every time like a new one comes, and not every time, like I said, I've had a few, and I've heard of a few more that state like, I don't know about you training blood. Like that seems sketch. And it's like, but it's in one of our core skills. So to be able to break down that barrier and trust us, it's like, no, this isn't Jeremy's just good idea fairy. I didn't watch a YouTube video on this. Like, this is in our protocols. And the one thing that's different from like Rangers, we go, they go through RAS level 2. Is that right, Jake? Is that what you said?
Yeah, sure. Yeah, that's about right. Sounds good.
Oh, yeah. They go through RAS, right?
Yeah.
They go through a selection. Like you said earlier, we don't, or ours don't. So there is that delineation. Like, they have not ate the same mud as us. They are, for all intents and purposes, outsiders. So going in there and making yourself available to the men and to the teams, and being that, like, hey, how can I support you? Right? What are you having trouble with? just asking those open-ended questions and then getting the feedback, but also doing something with that feedback. Not just, a good therapist of like, oh, okay, you don't like that. Thank you. I'm going to shelf this for never going to look at ever again. Right. So that's something that's huge. Teaching again, same as I imagine what Brenton will say as well. It's like, we don't know it all. We know you're the big brains. So teach us your knowledge, and to regress back to the battlefield extender, right? Where no MTF gets any patients if the team medic doesn't treat them properly and do the stuff and things that they need to do to get them back there. So that person being, having all the knowledge does no one no good, because they're in some, battalion aid station or some talk or jock somewhere, watching TV or, playing FIFA, whatever they do. Right. But, and to be our voice, like they're back there, be our voice for us when we come up with those concerns, those, like, hey, I need class aid, or hey, I need this. And that, that request for supplies goes up, and they're like, hey doc, do they really need this? Like, it's not their job to question us. It's also our job to reach out ahead of time and go, hey, I'm requesting this. These are the justifications for it. But like, also, yes, they need it, because, who are we to question that? What is it? The men, the mission, and me, the ground truth, and the men on the ground, trust them. That, I was just, they all new battalion docs read that. And then critique our notes. Like I said earlier, like, no one gets better by saying, for lack of a better term, getting our knees dirty, right? Let us know what we're messing up with our patients. Help us be better providers in the team room. Because I imagine, though, this is going to sound like a backhanded compliment, but it's not. None of you are providers. We are. Most of our team room medicine is in the team room. Like, hey, hey, Paul, hey, Brenton, hey, Jake, like, I got this thing going on. What can I do? And so if we're not equipped with that knowledge, as we put in those notes, like, hey, you saw this dude when you were at this training site, that, again, that's a bad thing. I think, Brenton, you alluded to earlier, like, yeah, SOIDCs where we go, a lot of training, and everything's, not local by any means, but we have the ability to log into Genesis, or, take a picture of a SOAP note, and they can upload that into their health record back there. So he's able to see our, the patients almost as much as real time as can be, and help guide us with that. Even if it's, some basic sick call stuff, you're like, hey man, augmentin is really good for otitis media. You might want to think about that instead of, whatever. Yeah. I think that's about it. Again, new providers, it's you're stepping into a whole new world, because you're going to dudes who've been assessed and selected. Again, unlike Rangers, we don't have someone who does that. Like I said, they go through the pipeline, then we get them. So it could be someone who can be there and speak confidently about their capabilities and their knowledge, and go, this is my world. I'm really good at it. Teach me yours. I'll teach you some of mine, for the common goal of this. Common goal of making you better providers. Making sure that, patient continuum of care is at the best practice, not subpar. Things like that.
Yep. I mean, one of the main jobs for the provider for the command is to give, the medical opinion about whatever it is they're going to go do. If you don't know anything about your medics, everything coming out of your mouth is bullshit, because you don't actually know what's going to happen. you can say, well, I looked it up on, Wikipedia, and this is what the medic should be able to do. So I'm going to make my plans based off of that. Probably not a way to do business.
I do my medicine off of Wikipedia, so I wouldn't knock that exactly, Dennis.
Yeah, I mean, that's not what I meant. That's not what I meant. Like, Wikipedia is freaking awesome, and you should definitely trust it with somebody's life. But maybe not your own. But
again, it's in some people's units. It's in their pipeline. Congratulations, you're a doctor, you're a PA. You go to Fort Liberty, to Sockamus, to Refresher, right? And you audit a class.
Yeah.
Again, if Jeremy was king for a day, whoever's listening on the Ethernets, if that would be like the SOCOM directive that all providers that support that have to go to that course upon checking in within the first 90 days, that would be super cool. I don't know who's listening, but if Jeremy was king for a day, I would love that, because that would cut a lot of noise out.
Yeah. And I would extend that beyond just providers, like planners, etc. Anything that has anything to do with medical support in any way probably should see what happens on the ground.
Yeah, and within that first 90 days, you can't. And I say that is there was a unit. The dude was leaving within the next 6 months, and he came, which is cool. He came, but allegedly he's been there for a couple hundred days beforehand.
Right.
I would say target missed. Realign your sights there.
Yep. Brenton, brand new doc.
Yeah.
Volleyball or what?
They need to be very up to date on hair gels. They need to be very up to date on golf, drinking strategies, all the game. Yeah, exactly. They need to have a ghostwriter on call. That's the biggest thing that they can do.
I'm sorry, I keep picking on you, but like it's
part of the game, I guess. We did it to ourselves. I think that Jake and Jeremy really hit a lot of good stuff. I have two things that I'll focus on. The first is, it's kind of been touched on a little bit, is getting out into the field, going on trips and seeing training and seeing how guys work and run iterations, from POI incidents where it's a simple GSW to somebody who's an IED or crush patient, or they have something neuro going on and you have to sit on them for a couple hours, and seeing how they do with more complex injury sets in PFC. I think being able to see in person the actual skill sets and the ways guys work through stuff is huge, because it gives them a baseline understanding. We just stood up an MOU, a new hospital rotation up in New York, and we are flying down a couple ER doc and a trauma surgeon down to watch training for that specific purpose. So they can go back, and the rotation done great so far, but when they are able to see people work in the field and they're able to see what the skill sets actually are, I think it translates a lot better when they go back to a hospital and when they're doing, training. So I think that's my first real point for providers coming in, at least on the NSW side. That might correlate with what you guys want as well in the other sections, but for us, I think that's huge. The second piece is support. Guys know what they need, especially the senior medics, whether that's equipment, whether that's training. They are very vocal a lot of the times, and you have a range of personalities at the top end that are receptive or unreceptive. And I think being on the receptive side and trying to provide that material support, training, opportunities for the medics is only going to make them better. And it's going to strengthen the relationship and the trust from the medics going up the line. So if you want to create a good relationship with your guys and make them feel like you have their back, showing them that you support them, I think is paramount. And I think with that, Jeremy kind of touched on it. They are the SME. Like they know more than we do. It's just a matter of fact. They might not be as good with like TCCC, but everything else, especially clinically related, they are the subject matter experts. So I think having confidence, even if you're a junior, to be able to give information to guys and help teach them is huge. And I would say on the same end, if you want to have the relationship be a two-way street, you need to humble yourself a little bit and be able to learn from the guys, because if you have a guy who's on his 5th deployment, he probably has something to teach you. If you're a brand new PA, he probably has something that you can take away from him, or some training he can offer you to make you better, whether that's giving an IV, drawing blood, whatever it is. He can help you in some way as well. So I would say support, and then have an open mind with training. Try to give them something and try to get something back yourself.
Yep, very good. Paul, round us out.
Yeah, I took a couple notes while they were talking. I really do like the thing about being an advocate. So a lot of the medics will come up and say, hey, this is exactly what I need. I mean, if you look at Ramey Wilson's work, like there's studies showing that we know what we know and we know what we don't know. And when we ask for the things that we don't have, it's because we know we don't have them, if that makes sense. So if I tell you I need training in PFC because I'm going to this country and I know there's no surgical team, it's not just because it's a nice to have because it's cool training. It's because it's for a reason. Our training calendars, if you ever go down into a team room and check them out, there might be like 3, maybe 4 days of medical training on a training calendar. So you need to go in there, and if they ask for more training time, you got to have their back. You got to know the standards and the regulations. So depending on which unit you go to, just the stuff you've heard here. If you're coming into SF, if you're going over to the Rangers, you're still in USASOC, you go into the Navy side, you got to know the different regulations. And then you have to also be willing to hold your guys to those standards. That is part of the job. That's probably not the easiest part of the job, but hey, if they can't do a crike, if they can't do a junctional tourniquet, if they don't know how to draw blood in a timely manner, those are things you need to make sure that they know how to do before they go out the door. Their main job is to be a staff officer to advise the commander on risk mitigation. If you're not advising the commander truthfully, kind of like what you were talking about, again, that's going to be bullshit. And then somebody's going to get hurt. Training records get pencil whipped. Things come back on people. So don't do any of that stuff. You got to know the TMEPs for SF guys. You got to know the SF Med Handbook, even though it's old. That's a great training thing. You could go through that thing, pick out one of 1,700 pages that's in there. Say, hey, this is out of date. Go down there and talk to the guys. This new study came out. It postdates what says in your SF Med Handbook. So that's a good way to do that. And then you have the clinical practice guidelines. There are a lot of soft medics. We see it all the time that still don't know what a CPG is. So if you're a provider, get on the JTS website, the Joint Trauma Service website, and start looking at the prolonged field care CPGs, because those will inform what goes into some of these other handbooks that we've been talking about. A couple other words that, like Jeremy said, you got to put $1 in the swear jar. 72 hours. You can't say that. Medics can't hold on to a patient for 72 hours. And the other one is 18 deltas are almost PAs. You can't say that either. And I think that really hurts what we're trying to do when people say things like that, because they say they don't need that training. They don't need that piece of equipment because they're almost PAs. They can hold on to a patient for 72 hours. It's terrible to hear that because depending on what the injury is, that's not possible, especially without the training or the equipment you're trying to get. So,
hold on.
Go ahead, Jeremy.
I
rile you up, huh?
Someone tried to tell me that I need to put PFC or PCC on a con-op. Like, oh yeah, just
Oh boy,
and your C, just put PFC, PC. What? No. With what? With what equipment? And they're like, well, you can hold on to them. I was like, yeah, if I have the equipment, the supplies, the personnel. Jeremy is a one-man national asset with no Tempest, no oxygen, hopes and dreams and duct tape. That, hey, like this isn't gonna cut it. And again, like you said, like one moonset, it it's like I listen. I'll be lucky to hold on to him for the 15 minutes, much less hours. Like to your point, I'm sorry. That is one of my obviously. I've had this argument a time or two, but please do not say that because the
Yeah.
arbitrary numbers upset me.
Yeah.
Yep.
So as a medical officer, you got to advise your commander with realistic information. Obviously, we just debunked that one for you, so that should never come out of your mouth. The last stuff, a lot of SF guys are going to give a lot of pushback if you give them a lot of knife hands and things like that. So you got to get in there. You can motivate, mentor, and guide, but that's going to give you your best results by far from what I've seen. And then these guys said that you need to go to the course, like go to Dennis's course, get down there, see what actually happens there, see what doesn't happen. We talked about dental and physical therapy. Not a lot of that happens unless you're doing non-trauma training. There are other indoctrination courses. You can go to JSOMOC, right, down at the JSOW in Tampa. You can go, if you're in 1st Special Forces Command, you can go to SOMIC. I think they do it once a year. And you'll get a week of extra training, kind of your indoctrination course. So it just lets you figure out who's who and who your touch points are. I think that's pretty much what I have for that portion.
Cool. Well, it's starting to get kind of late in the podcast, so do you guys have any kind of final thoughts?
I'll start off this time.
I can talk.
Sure,
I can talk about this for hours.
Yeah, we have before.
Paul's all got me fired up over here.
Yeah, at the end of the podcast. I would just say that SOF medics are selected, trained, equipped, and assigned to do an operational thing, and you need to be there to support them as a support guy. And they're going to be supporting some other effort. Everybody supports somebody else until that trigger gets pulled. So help them do their jobs.
Yep, absolutely. Go ahead, Jeremy.
I would say like the things that I said, like need provider. I've been super lucky. One of my last battalion surgeons, like a lot of us, have admirations, to get out, go to PA school or med school. And he found research opportunities for us. He was like, hey, it's good to get published. Like, let's do this. Also, we wanted to start this, me and another guy walked in his office like, hey, what do you think about this program? And what initially started out as like a good idea fairy has now turned into this amazing, wonderful thing with like float tanks and red light therapy and stuff like that, because he took it and he was like, yes, I love what you guys, what do you guys think about this? Will this be beneficial? Getting our feedback and then running with it. So none of the things I said is because I've had crappy ones. It's because I've had great battalion surgeons and PAs that have really spearheaded what I think is expected of them as a team medic.
Cool. Jake, Brenton?
I agree with Jeremy there. I've had really good experience, like up through the entire chain of command, all the way up to the regimental surgeon. It's been really, really good. I couldn't have asked for a better group of people to like learn from. I've gotten into PA school because of them. They were my influence to go to kind of. Yeah. No, no big deal. Anyways, if I can do it, you can do it. Trust me. But so the research thing is big. So we get a lot of guys going on these crazy research rabbit holes, especially on stuff like screening and stuff like testosterone replacement and all these kind of crazy, kind of off the wall Andrew Huberman stuff. I don't know if that's taboo to mention on this podcast. These like weird things, right? The doctor can kind of act or the provider can act as kind of a voice of reason, like, hey, like this study says this, what can I actually get from this study? Like it's a little bit more complicated than I think we make it seem. It's not just like the abstract and the conclusion. It's probably more than that, A provider definitely can like say, hey man, like I know that this says this, but like, got it. I know recently there was a study on TXA that's come out that's talking about IM TXA, You know, it's pretty small sample size. I'm sure that there's a provider that can really sell it to me, but I'm super unconvinced based on what I've seen so far. And that's something that, hey, maybe guys don't like to read research because they're not single E6s that live it by themselves. Hey, maybe he says, that study maybe doesn't really matter right now, but it might in the future, so keep it in mind. Just stuff like that can be really, really important.
Cool. Brenton, final thoughts?
Yeah, I think the last thing that I will say is, outside of supporting the medics with training and giving them all the resources they need to be good and save lives when they're doing training or when they're downrange, kind of touching on some of the points like Jeremy and Jake had, you as a doc, you as a PA are able to help push stuff forward, and you have a lot more of a say than a medic does. You might not know what the guys need as much, but you are able to help advance the needs at a higher level than they are able to, as a single E6 who's, reading studies all day. But, like for us in NSW, we just had there was a news article about it. We just pushed because of fatality in training a little bit ago. So they're doing PD testing across the force. That's great. There's concerns that come along with that guys at the bottom end feel that haven't ever been talked about at the top end. And I think from my perspective, I personally brought those up, and I had a great doctor who pushed those all the way up, and then they implemented some of those concerns I pushed across came out when they released everything. So a good doctor does that. They weren't tracking some of the issues that I brought up. It wasn't on the radar. And at the top end, if you're working with admirals and stuff, you're so far out of the picture that you have no idea what's going on the bottom end. Sometimes it takes a intermediate provider or a top end provider on our end to push those agendas to the very top and get them sorted out on the way down. So I would say be active in listening to your medics and help push stuff forward when it is relevant and needed.
No, very good. I just want to say thank you all very, very much for giving me your thoughts.
Thanks, Dennis.
Thanks, Dennis.
Cool.
Yeah, thank you. I appreciate having us on.
I don't think you've given me enough compliments, Jeremy. You might not come on next time. Cool. Hey, thank you guys. That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC podcast, out.